Hi, good afternoon, everyone. Thanks for joining us today to the CAQH Core webinar titled No Surprises Here, Recommendations from the Core Advanced Explanation of Benefits Advisory Group. So in today's session, we'll start off with an overview of Core and then get into a level set and background on the No Surprises Act. We'll then hear from Core staff about recommendations for the exchange of good faith estimates between providers and payers, and we'll round out today's session with a Q&A. You can download the slides now from the handout section of the GoToWebinar menu. You can also download the presentation slides and recording on our website after the webinar. Additionally, a copy of the slides and the recording will be emailed to all attendees and registrants in the next couple of business days. So feel free to circulate that recording and those slides with anyone who you think might be interested from your organization. Finally, if you have any questions, please submit them using the questions panel on the right of your screen. With that, I will turn it over to Erin Weber, Core Director.
Good afternoon, everyone, and thanks for joining us this afternoon for most of you on the East Coast. My name is Erin Weber, and I'm a director with CAQH Corp. My colleague, Bob Bowman, also Core Director, will be speaking later on the call. I wanted to give those of you who may be newer to the organization a little bit of background on CAQH Corp. We are an industry-led group of participating organizations, including healthcare providers, plans, vendors, government entities, associations, and standard-setting organizations that come together to develop operating rules or business rules that set parameters around how healthcare administrative data is exchanged to support the standards. Health plans participating in Core represent about 75% of the insured U.S. population, so we do have a robust membership. And we see our role not only to develop operating rule requirements through various subgroups and work groups that we have that our participants join, but also to develop, test, and iterate those requirements, drive adoption through our certification program, and measure the impact through our pilot and measurement initiative. We also do a lot of industry education and outreach through webinars like this one we're having today. Next slide, please. Core is designated by the Department of Health and Human Services as the National Operating Rule Authoring Entity for the HIPAA-mandated administrative transactions, which means that some of our operating rules are federally mandated for certain HIPAA transactions, and others may be in the future. We have over 120 organizations that participate in our rule development process. This slide gives you some sampling of the diversity of the membership. It's really interesting in our subgroup and work groups calls to hear these groups come together and come to consensus on potential requirements or recommendations for the industry. Next slide. As I mentioned before, we do more than just operating rule development. We have our participation activities, pilot and measurement, education and outreach, and core certification. And one of the areas where we do a lot of work is on policy. Oftentimes, our board and our participating organizations will provide feedback on certain policy issues and/or make recommendations on areas where the industry may need some guidance on interoperability issues. Next slide. I'm now going to talk a little bit about the No Surprises Act and why it was such an important issue for CAQH Corp to begin working on. The No Surprises Act was signed into law as part of that Consolidated Appropriations Act of 2021. And the purpose really is to address surprise medical billing. So those patients that receive unexpected medical bills that they can't afford long after the time of service. The No Surprises Act includes the concept of an advanced explanation of benefits, which is essentially an EOB that a patient or a health plan member would receive in advance of their care that would share information and transparency on what providers are expected to provide the treatment, the expected cost the network status of the patient, and what that particular patient will be responsible for financially. To support this, the section 112 or 112 of the Act also requires that healthcare providers and facilities verify what type of coverage a patient is enrolled in. That typically happens. But then they also need to provide notification of what's called a good faith estimate of charges to either the payer if it's an insured patient, or directly to the patient if it's a self-pay or uninsured patient in advance of the service, so that either the patient knows their out-of-pocket costs or the health plan can use that information to create that advanced explanation of benefits for their member. Next slide. The No Surprises Act lays out some very detailed requirements around the type of information that must be included in that advanced EOB, and it must be shared with the member or patient by either mail or electronically, up to the individual's preference, and include information, as I mentioned, about the network status of the provider or the facility, and the rates that are contracted, and or how the individual can find the contracted facility. If the provider is out of network, how that individual could find information about contracted providers or facilities. And then information around expected charges based on billing and diagnosis codes, estimates of the plan's payment responsibility and member cost sharing, amount the member has incurred toward meeting their financial responsibility limits, such as deductibles and out-of-pocket maximums. The advanced EOB can include disclaimers that the coverage is subject to prior authorization requirements, and the estimates may be subject to change, and anything else the health plans deem appropriate to include consistent with other requirements. So this is a lot of new information that would be available to the patient about their specific service or item prior to the point of service. Next slide, please. So when you think about those requirements, those of you that are familiar with the healthcare revenue cycle probably realized immediately that these are not workflows that currently exist in the healthcare revenue cycle, and there are certainly information being exchanged between providers and health plans on a regular basis, but not necessarily that specific good faith estimate information. And similarly, within the No Surprises Act, the provider is responsible for estimating their charges and potentially coordinating with co-providers who may also be involved in that service. So if you think about a surgery, the anesthesiologist, the facility fees, to develop that good faith estimate of service, or good faith estimate for services. And so there's just a lot of new information exchange needs and potential for industry to start developing proprietary approaches, which for those who have been in core for a long time, know that that is something that we worry quite a bit about, as it often increases costs and burden on all stakeholders. So in August, we launched a advanced EOB advisory group as a forum for stakeholders across the industry to collaborate and build consensus around initial recommendations for how to implement components of the No Surprises Act. So we had about 30 organizations and 60 participants from those organizations, representing all our stakeholder types, come together to think through some of these workflows and develop some recommendations on how they could be implemented. The group first focused on the exchange of good faith estimates between payers and providers. So remember what we just talked about, section 112 of the No Surprises Act requires that the provider send the health plan a good faith estimate of the services, so the health plan can use that information to create the advanced EOB. So we chose that scope in part because CORE has typically worked between those provider to health plan data exchanges. And so the advisory group met over the course of 3 or 4 meetings to evaluate various implementation approaches in detail, and went through a process of surveying, voting, and determining where there was consensus, which in this case we really determined as at least 2/3 support within the group to develop a series of recommendations to provide guidance on standardized approaches to facilitate the exchange of the good faith estimates. Next slide. So this slide really lays out the workflow of the advanced EOB from start to finish. So, the patient schedules their appointment or requests the cost estimate, and that's what triggers the development of that good faith estimate and advanced EOB. So the provider then verifies insurance with the health plan. If the patient is uninsured or self-pay, the provider then sends the patient a good faith estimate of expected charges. If the patient does have health coverage, the provider sends a good faith estimate of charges to the health plan, and that is the scope of the work that we have started with our advisory group. Then the health plan sends the advanced EOB to the member, and the health plan could also send that advanced EOB to a provider. We've heard, especially from the provider community, that would be an important communication to occur. So that is the initial scope of the work. We published a paper, which Bob will talk about in a minute, a couple weeks ago with the advisory group's recommendations. We do anticipate that the group will continue meeting to address other use cases in this space. But for now, I'm going to turn it over to Bob to walk through the recommendations from the advisory group.
Great, thanks, Erin. And just as Erin mentioned, we do want to walk through just the general process and the recommendations that we developed from the advisory group. As you can see, we did publish this last week. We have a link here for you. And it does really illustrate that the industry can meet these requirements if we look towards what the industry has already implemented and what kind of things that the industry needs to do to move forward. Really looking at some key components, and the advisory group helped identify some of those key components. So if we can move to the next slide, we can kind of look and see exactly kind of where the environment is within the industry and what this might mean for us as we look towards solutions and meeting the requirements for a good faith estimate. Some of these key elements that the advisory looked at were messaging standards, right? There are potentially proprietary formats to use, X12 standards to use, and also implementation guides that may be published by HL7. As you can see, there's quite a variety that could potentially be used, but how can we as an industry move forward with an approach that everyone can kind of get behind, support, right, drive that consensus-based approach, and find things and mechanisms for these types of messaging standards that can support lots of different things. Basically, you have to have connectivity, you have to have data, you have to understand either the complexity of the environment that this type of data is being exchanged in, and what kind of interoperability there exists between a provider, the provider's vendor, which could be their practice management system, their EHR system, their clearinghouses that they're contracted with, as well as the health plan and their vendors. Oftentimes, clearinghouses, are in front of those health plan systems for that data exchange. So that environment can be quite complex. So how do we ensure that we have each of these components specified in such a way that providers can actively engage with health plans to ensure the right data is submitted to generate a good faith estimate, and that the health plan can then provide that good faith estimate back to the provider in a meaningful way, right? All of these components have to be thought of as we move forward with any sort of industry recommendations. And what the advisory group has done, if we look at the next slide, we do have some recommendations for the industry to consider. And these fall into generally three buckets. And we'll go into more detail in each one of these. But generally, there are messaging standards that exist today and are being developed today that should be considered for use. There are also connectivity methods, right? How do we connect a provider to a health plan, potentially using many of those intermediaries that are key to data exchange in today's world for the same type of data exchange in tomorrow's world when we're exchanging information about a good faith estimate. And not only is there the connectivity method that's required, we also have to have uniform data content. So there are different sets of data to ensure that the provider collects, puts within a transaction or puts within an interaction with a health plan, submits that data the data has to be evaluated by the health plan in a meaningful way so the health plan can develop that good faith estimate and report back to the provider what that dollar amount is, right? Because there's very specific sets of data that's required from the provider to be, I'm going to say it, adjudicated by the health plan to ensure that that good faith estimate is as close as possible to meet some of those requirements within the regulation. Now, we're going to go into just a little bit more detail on each one of these topics in the next couple of slides, just so you can get a more firm understanding of what the recommendations are. So the first one is related to the specifics for the standard. And the standards, again, there are existing standards today developed by X12 related to predetermination claims, whether that is a 5010 version or a future version of the transaction that exists that has those particular indicators in it for predetermination. And really the industry can look towards the dental industry because the dental industry has been using the 837 predetermination transaction for quite a few years now. It's been really successful in determining what those costs are to a patient for those dental services, right? Dental providers can submit a predetermination claim, get the information back on what those costs are, and share that directly with the patient while they're in the office. So that type of model is exactly kind of what we're looking for here in the medical world. And so that same type of transaction where you have a certain indicator, a certain field in the claim, to turn it from a payable, billable claim into something that is an estimate or a predetermination, or what is the cost of this service to the patient as it hits that patient's benefits, as it hits that patient's deductible, as it hits those patients' other financial components like secondary insurance. Those types of complicating factors for medical are all really important. But initially, what the provider has to submit is going to be key in determining that what that transaction looks like. It can't be a billable claim, right? We don't want this to actually bill and pay. We want this to not bill and pay, but have the same ending result as a fully adjudicated claim, because that information is exactly what the provider needs to share with the member. Last but not least, in this type of standards discussion, FHIR-based methodologies and implementation guides developed by Da Vinci are going to be key components as well, because the work that they're currently doing may really help for some of those more advanced entities and health plans and provider communities that have those advanced technology capabilities. They may be able to jump and kind of leapfrog ahead into more of a real-time based transaction and adjudication process that would allow for that kind of interaction to take place. So we are monitoring those developments, and we'll be sharing that with the industry as we move forward. So we just want to make sure that you're aware that there are existing standards today that can support this, as well as new standards being developed for tomorrow. On the next slide, you'll see that we often, we do have to make that connection between the provider and the health plan. So on slide 18, we do have that connectivity method that allows for that interaction to take place. Sorry, I'm not showing our slides of being advanced. To the next slide. There we go. So we do.
And Bob, this is Erin. We're just getting a couple messages that your sound is fading in and out. So if you could just stay close to your mic, that would be great.
Great, thank you. Thanks for the feedback. I'll try to stay within the mic zone. So here for core connectivity is definitely a mode for connecting providers to health plans. Core connectivity has been in existence since 2006, has been modified to adjust to current both industry standards for security as well as for connectivity, and ensures, because it is required for support of many of the HIPAA transactions today, the providers and health plans and their vendors are already conducting transactions through this mode. Other technologies, again, like HL7 APIs, using HL7 FHIR bundles and resources are also being developed and are in use today. So there are models for data exchange that exist and are central for providers and health plans and everyone on the call today to consider as we move forward for the data exchange. And on slide 19, on the next slide, you'll see that there are very specific, as we mentioned before, very specific types of data that is required to ensure that both a provider collects the data and submits that data, and that the health plan needs to ensure that they have everything that the plan needs to adjudicate that predetermination or that estimate to hit that up against the patient's membership file. Basically, that claim has to be adjudicated and has to go out as if it were really going to be a paid claim. So there are going to be specific sets of data specific around the patient, around the provider and the facility that will be conducting the service. There is very specific information and data related to that exact service. And for example, we know not only is a data service or procedure code and diagnosis code really important, but even the modifier can have significant impacts to how the claim is adjudicated and what that pay amount is. This is going to be really key too for those folks that have commercial insurance or government-based insurance, and especially for those that have are self-pay procedures. If the member is paying out of pocket for the entire procedure, all of these very specific pieces of data are key to how that claim will be adjudicated and how those estimates will be developed and formulated by the health plan and then sent back to the provider for them to share with the member, right? If that's the intent of the regulation and the intent of the process, we have to make sure that each piece of data that's required for that nuance of payment is included as well as used in the adjudication process. And finally, on the next slide, we do have some tentative next steps for the work that the advisory group will continue to do and consider. We will be having our next call on December 14th from 2 to 3, so please join us if you're a participating organization, or if you want to become a participating organization, please check with us at core@caqh.org and we send you the information for that. But we're also going to continue to develop recommendations for the comprehensive advanced EOB data set with a common flow and format across all advanced EOBs, as well as conducting an environmental scan for the provider exchange of services and estimates performed during a patient scheduled visit. Right? I know a lot of discussion around the provider role in this process is taking place, and a lot of times we get into that rabbit hole, but we want to make sure that we have a really good firm understanding of what that might mean, what that is, and what that exists of. So we'll be reaching out to many of our provider participants as well as to the broader community to understanding exactly what the anticipated transactions or interactions and exchange of that information will be. So please continue to stay abreast of what we're doing here. We'll be continuing to publish things out for you and continue to host other education events throughout the year. So with that, I'll hand the call over to Daphne. I know we have some questions that have come in both through the registration process and online this afternoon.
And Daphne, before you get started, I just want to highlight that this is a really short webinar and there is a lot of information in the No Surprises Act and including around advanced EOB. CMS has released a couple regulations now with more detail on the requirements. There have been FAQs posted from CMS and the agencies as well around enforcement delays around some of the requirements to allow the industry to have some time to identify standards and uniform processes and frameworks for implementing components of the advanced EOB. So while there is a little bit of breathing time to think through how to do this in the most efficient way possible, I think there is still some urgency within the industry to move things forward given the delays are only around a year or two. So all that to be said, please reach out to us if you're looking for more information. We certainly couldn't include it all today.
Yeah, absolutely. I'll jump straight into the first question then for you, Erin. So what components of the AEOB process have already been addressed by regulation?
That is a good question. So recently, the agencies, and that's HHS, Treasury, and Labor, released a regulation. The first that came out didn't have much about the advanced EOB in it. The second, part 2 regulation, addressed the exchange of the good faith estimate for that uninsured and self-pay scenario. So looking to the provider, when a uninsured or self-pay patient asks the provider for an estimate or when they schedule a service, that provider, who is determined to be in the regulation, the convening provider, would work with co-providers involved in that period of care to collect cost information to then send to the patient a good faith estimate for those specific healthcare services or items. So that was really the scope of the advanced EOB components within that regulation. The agencies have been clear that the actual advanced EOB component, which is from the health plan to the member, there is need to spend more time thinking about standardization and uniformity and how those requirements can be implemented. And so the agencies were clear that nothing would come out on those requirements before the first of the year, but anytime after that is fine.
We also have a few questions coming in around who the ruling applies to. So can you clarify whether the ruling applies to any services performed outside of a hospital setting?
Yes, let me take myself off mute. The answer is yes, it's applicable to all service in and out of network by providers and facilities. So it's quite broad right now in the coverage. You know, I was at an industry event yesterday where there was some discussion around providing feedback to the agencies about potentially being less broad. Obviously, surprise billing issues happen most commonly for, you know, emergency care or large types of procedures, and not necessarily your typical office visit. So that is an area where I think the healthcare industry will be providing feedback to the agencies, but as of now, it applies quite broadly.
Thanks, Erin. Another question here. How should GFEs be handled when there's a high level of unpredictability around these specific services to be delivered?
I think one of the challenges with the information we have to date around what's in the legislation, what's in the regulations that have been released to date is that there's still a lot of unknowns and questions out there. And I know there are industry organizations like WEDI, for example, that are working to aggregate the issues and the outstanding questions to share with the regulators. You know, in some instances, it may be industry can kind of determine and make some assumptions to move forward. In other instances, there really is more clarity needed in terms of what the key components or requirements are within the scope of the AEOB.
As you look into your crystal ball, do you think that the AEOB requirements in the CAA are likely to be delayed?
Well, we already know several of them have been delayed, right? So as I mentioned earlier, enforcement has been delayed for providers collecting information on costs from the co-providers involved in the service of care. There was a 1-year delay on that. And also enforcement delay on the requirements related to the advanced EOB component in terms of provider to health plan and health plan to member exchange as well. So waiting on more guidance and regulation on that from the agencies. And, you know, Daphne, I just encourage everyone to, you know, get involved in the various industry efforts going on in this space. Many of them are included in the guidance document. It's really going to take feedback and support from all of the stakeholders involved in the AEOB workflow to truly understand how we can design a way to exchange this information most efficiently. So really encourage your organizations to get involved in the work.
Thanks, Erin, and thank you guys for the great presentation today. I know we covered a lot. We have a lot of questions pouring in, so please contact us at core@caqh.org if you have any follow-up questions or would like to get involved. Have a great afternoon, everyone.
Thanks, all.